Okay, so what we're doing today is we're going to go over pediatric ENT lecture. This lecture has been modified for the fall of 2020. It's all about the PANCE. That is true. 7% of the PANCE is based on ENT material, so it is not super high yield for PANCE, but definitely something you want to know, and there are a lot of patients who are going to come in with ENT complaints, particularly if you deal with a pediatric population. So this is how the PANCE has it broken down. The key categories and pathologies that they want you to focus on for the PANCE exam. So you've got eye, and then all of the eye problems and disorders, as well as ear, foreign bodies, neoplasm, nose and sinus, and oral pharyngeal disorders. I recommend that you go over these and make sure that you have these all on your radar before the exam, as well as definitely before the PANCE. So here's a little review of the anatomy of the ear. So when we're talking about the external ear, you're talking about the pinna right here, and you've got your little tragus right there, the auditory canal, and then everything up into this tympanic membrane is considered the outer part of the ear. Then you go to the middle ear. The middle ear consists of the bony structures of the ear plus this middle ear component, as well as the eustachian tube. This is largely used to transmit sound from the tympanic membrane into this cochlea and semicircular canal that then distributes the sound into a neural stimulus and into the brain. So we'll discuss some of the abnormalities and the differences that we see in children with ear. Probably one of the biggest ones is that this eustachian tube is very small, often can get clogged, and children can be more prone to inner ear infections because of this small eustachian tube, or clogging of the eustachian tube, if you will. Next, we're moving on to the sinuses. So we have the frontal sinuses, which live about here. And then you have your maxillary sinuses. These are your two big sinus passageways. You've also have the ethmoid sinus, which is kind of here, and near the medial part of the eye and nose. Next, we'll look at the oral pharynx. So you've got your hard palate here, and then the soft palate, which is much more palpable. And then you have the tonsillar fossa. You've got the epiglottis here, and then down into the esophagus, there's the larynx as well. So the outline is basically we're going to talk about some hearing and visual problems. We're going to go over some common eye infections. We'll dive into the ear and the nose, as well as the mouth and throat, and then finish up with a little bit of lymphadenopathy and adenitis and some things that we want to make sure that we don't miss. So types of hearing, so there's different types of hearing, one being conductive hearing. So a sound comes in through here, it is conducted through this tympanic membrane and through the middle ear and then into the inner ear into a neurostimulus. So if there is some sort of block in this conduction, we can have conductive hearing loss, which is the most common cause of hearing loss in children. Another type of hearing loss is sensorineural hearing loss. Sensorineural hearing loss has to do with the sensation of sound and then the distribution through the neurosensory component. There's also a mixed form, which basically combines these two forms of hearing loss. So some tests that you really need to know, these are high yield for many of the tests, as it's just easily testable material. This is the Weber and the Rene test. These tests are both used together to help and investigate the type of hearing loss that is involved in a patient's complaint. Here you have the Rene test. So with the Rene test, what you do is you strike the tuning fork. The tuning fork is placed at the mastoid process. Then when they can no longer hear this type of sound, then they alert you to that, and then you place the tuning fork in the air next to the ear, and that helps you elicit either what type of hearing loss there is or which ear it lateralizes to, because that is all important information. The Weber test is another test that is utilized to assess for hearing loss. So with the Weber test, you should have, when you strike the tuning fork and you place it at the crown of the patient's head, and the sound should be equal in both ears. It should, what they call, lateralize to both ears. If you have a conductive hearing loss, in other words, the sound is not conducting very well, maybe the canal is infected or blocked, the sound actually lateralizes more toward that sound, so that obstruction is actually causing the sound to be kind of trapped in the ear, and it actually appears louder in the affected ear. If you have a sensorineural hearing loss, say in this ear, then if the Weber test is going to identify sensorineural hearing loss, then it's actually going to lateralize to the opposite ear. So that doesn't give us a lot of information unless we utilize it together with the Rene test to really verify which type of hearing loss and which ear is infected by that hearing loss. Okay, so let's review kind of how these two tests work. So this is the Weber test. The Weber test tests for conductive and sensorineural hearing loss. With the Weber test, what you do is you place the tuning fork on the top of the patient's head, and then it will equalize either to both ears, or if there's conductive hearing loss, it will localize to the bad ear, and sensorineural hearing loss will localize to the good ear. We will take a look at these here more in depth. So if we put it all together, you've got the Rene test, and normal with the Rene test is that air conduction is greater than bone conduction. So AC is greater than BN. And then with sensorineural hearing loss, you have air conduction greater than bone. And with conductive hearing loss, you're going to have bone conduction greater than air. So the Weber test localizes toward the side of a conductive hearing loss and away from the side of a sensorineural hearing loss. So let's try to distill this information. Okay, so I got a little bit bored my cheat sheet here. So here. So we've got, here is the Rene test, okay? So what we do with the Rene test, what the Rene test does is attempt to assess if air conduction is greater than bone conduction. So a normal test for the Rene test is to place the tuning fork over the mastoid process. Once the patient can hear the sound, then you change it to the air conduction. If both ears air conduction is greater than bone conduction, then that is a normal test. It would be an abnormal test if bone conduction is greater than air conduction. That would indicate a conductive hearing loss. To ensure that that's a conductive hearing loss and not a sensorineural hearing loss, we use the Weber to differentiate. So a normal Weber test is going to go to both ears. If you have an abnormality, it will either go to one ear or the other. That's an abnormal test. We have to pair that with the Rene to find out if it's sensorineural or conductive hearing loss. So say that the Weber localizes to the right ear. If we're dealing with sensorineural hearing loss, then we can indicate that this ear is the ear affected. But if we're dealing with a conductive hearing loss, then going to localize to the side with the conductive hearing loss. So when you put the two together, you really come up with a good idea of what type of hearing loss you're dealing with. So I attached this video link here, which I would like you to copy and paste into your browser and watch. It's a helpful way to kind of bring all that information together. These tests are very highly found in the PANCE testing, as well as on the exam that will be for just you guys, your PA exam. Okay, so let's talk about some congenitive causes of hearing loss. So we've got conductive hearing loss, which can be caused by malformations in the pinna and either the canal, which would not allow sound to come through. You can have a tympanic membrane problem or a problem with the ossicles where they're not actually conducting that sound down into the middle ear. Sensorineural hearing loss can be caused by genetic syndromes. This is the most common. The most common cause of sensorineural hearing loss is a genetic problem. The most common cause of pediatric hearing loss in general is conductive hearing loss. So that some of these sensorineural problems can come from uterine infection. So cytomegalovirus, herpes, rubella, syphilis, toxoplasma. A lot of these viruses can cause sensorineural damage, resulting in sensorineural hearing loss. If there's a cochlear abnormality, you can also get hearing loss. And then uterotoxic medications or drugs can cause hearing loss as well. Also, kernicterus, so too much bilirubin built up in the blood can cause sensorineural damage and then result in hearing loss. So let's go over these. We've got conductive hearing loss. These are types of acquired hearing loss. So hearing loss that occurs over time, right? You're not born with this. That would be a congenital hearing loss. This is something that you acquire as life goes on. So conductive hearing loss, otitis media with effusion. So right, you have a ear infection, you end up with some hearing loss from that. That would be a conductive hearing loss. You're not conducting that sound through. You could have a foreign body. You could have a tumor called a cholesteatoma. And you could also have had trauma where either the tympanic membrane was perforated or the bones had been disrupted by a trauma. Sensorineural hearing loss can be caused by infections, some bacterial infections like meningitis, as well as some viruses there that are listed. Trauma can also cause sensorineural hearing loss. Radiation and neurodegenerative disorders are all big causes of sensorineural hearing loss. Screening for hearing loss. So universal screening is conducted on all newborn babies before they're discharged from the hospital. So they are on you and your baby, and you are going to get that baby screened before they leave. That is probably one of the things that they do within the first few days of birth to clear the child to be released. You just want to verify all the documentation and results, and if there's abnormalities, you're going to rescreen these children in 2 months. If there is abnormalities at 3 to 4 months, then we're going to refer these children to audiology. Other times that we check for hearing loss are during well-child visits. We want to always get a good history. We want to observe. We want to watch their development because this can be a sign of poor hearing, and we want to capture this early so that the child is not affected in their development. So we are always going to perform audiometry on these children, ages 4, 5, 6, 8, 10, 11 through 14, 15 through 17, and 18 through 21. Abnormal results should always be repeated after otitis media infection. So if a patient suffers from otitis media, we have an abnormal audiometry, we want to definitely repeat this after the otitis infection has resolved. Auditory brainstem response. So this is type of testing that we have for these children. So in newborns, we're actually putting this device on them, and then measuring their brain waves and making sure that they respond appropriately to the stimulus. And then later we have this evoked otoacoustic emission, which is also performed on newborns as well, which I'm not as familiar with, but it's another type of test that they use to assess hearing. Audiometry, we want to watch for behavioral. We want to make sure that the child is using words like they should, and if they're not, we need to refer these children early. We should do conventional audiometry at greater than 4 years. This can be done in offices and schools. So a lot of you taking this test, right? Can you hear that? Can you hear that? Can you hear that? And so that's the one. Tympanometry can also be done to assess that the tympanic membrane is working correctly. We want to basically capture these children early, because if they have a congenital hearing loss, we need to manage this early. We want to provide them with alternate means of education, and we want to make sure that they're developing correctly. Basically, our goal is to intervene with these children by 6 months of age so that they don't develop a long-lasting deficit in communication. So there's hearing devices that we can use, right? We can amplify the sounds. We can utilize cochlear implants. That's used for sensorineural hearing loss. So we can grade the amount of hearing loss that a child may have. They can have hearing loss from 15 to 25 decibels. This is a minimal or slight hearing decrease. They may miss about 10% of speech and may slightly respond inappropriately. This is kind of like, you know, your 50 or 60-year-old father-in-law that's, you know, shotguns for part of his life and hasn't used proper ear protection and might ask you, huh, every once in a while. And then you've got this mild hearing loss, which is up to missing about 50% of speech. And this is where you start to see maybe some behavioral problems or problems in their development. They even may think that the child is not paying attention. And so that's why we always want to be on it to make sure that these children are being screened appropriately so that we can identify things early. Moderate hearing loss, anywhere from reduction of 41 to 65 decibels of their hearing level. They may miss 50% to 100% of their speech quality, and may have a poor or limited vocabulary. This can be very socially isolating, can cause poor self-esteem and language problems as well. The role of the primary care provider is basically to conduct these screening tests. If we suspect that there's an abnormality, we need to go a little bit more in depth. We need to look for chronic or middle ear effusions that may be present. We also want to provide letters and notification for the school so that they can preferentially treat the child as far as like seating goes, any special accommodations that the child may need. And then educate the parents on some resources that are out there. And we definitely want to refer these children to audiometry and speech therapy as soon as possible. So here's some of those implants. These are the cochlear implants right here. This is a cochlear implant on the bottom. Okay, so it's actually implanted. It goes, the wiring goes into the cochlea itself and then actually transmits sound through there. And then here is a normal kind of hearing aid that increases the sound production into the ear. Okay, so now we're moving on from hearing, we're moving on to vision. So normal visual acuity. From 0 to 2 months, it's difficult to assess, right? They're gonna blink at bright light. They may sporadically fixate on objects or people. It's not really considered a strabismus until they're older than 4 months, because from 2 to 4 months, they may have this intermittent kind of strabismus, and that's pretty much normal development. From 2 to 6 months, they're gonna start following objects. They're gonna be fixing on these objects, and the alignment of the eyes should now be straight. From 6 months to 2 years, they may have, this is when they're really developing their depth perception. They may reach for objects. They're able to like stack blocks and things like that. At 3 to 5 years, we are able to use the Snellen test. So we can use a Snellen chart. And for these kids, it's a little bit different. We'll go over what that looks like in a minute. But they should be able to do this at least to a 20/40 or better. And then greater than 5 years, now they're at 20/30. No more than 2 lines difference between eyes, right? So the visual cortex is not completely developed until 8 or 10 years of age. So that's important to remember that as these children are developing, so is their visual cortex, and that we cannot fully assess them until about 8 years old. So here's what a pediatric eye chart looks like. These pediatric eye charts allow them to see shapes or symbols so that they can articulate that, and they don't have to read letters if they're not able to read their letters yet. And then there's also some modified pediatric eye charts as well. Vision impairment. So vision impairment, you know, with mild deficits, this is the most common. We call this myopia. This is nearsightedness. It increases during school age, and glasses are usually the corrective measure to increase their near visual acuity. So myopia, you can't see the objects very well or the words very well up close. If there's a severe deficit, usually the onset is with infants and young children. We want to refer these children to an ophthalmologist to make sure there's no anatomical problem with the eye, and that that they are fully evaluated by a eye specialist. Okay, so amblyopia. Amblyopia is a difficult concept and term when we pair it with the strabismus, which we'll go through these. So amblyopia is basically referred to as lazy eye. So it's unclear or unequal retinal input that's ignored by the developing brain. So you have this eye that's maybe not progressing as well as the other. And so the brain finds the easiest way to do it and uses the other eye. So this eye that's kind of has this muted input is basically ignored by the brain. Then it will kind of be this lazy eye because it will be all over. It's not really processing information. So from birth to 1 year, we really want to make sure that we're assessing this and that we're checking on the anatomy of the eye. There could be anatomical reasons for this. If they're deprived of input from either a corneal opacity, a cataract, glaucoma, retinoblastoma, some sort of congenital eye problem like a ptosis, where you've got this muscle that's not working correctly, or a hemangioma. From 1 to 8 years, we want to make sure that the alignment is normalized. If you've got unequal refraction, then you may have abnormal development. And this could be a permanent strabismus. So you permanently have an eye that is out of alignment. So some screening tests for visual impairment. So we want to get an ocular history. We want to check their eye movement, right? From newborn to 3 years old, we're going to do a visual assessment. We're going to look at the eye itself. We're going to do an external eye exam. We're going to check ocular mobility. We're going to test their corneal reflex to make sure that they're performing correctly. We're going to watch that pupil, and we're going to look for the red reflex because we should see that. And then we're going to do the cover-uncover test. From 3 to 5 years, we can measure their visual acuity. On our physical exam, we're going to do an external exam. We're going to look at the ocular mobility again. We're going to check the corneal reflex. We can do the cover-uncover test, and we can direct them. We can do direct ophthalmoscopy, so we can refer them to a ophthalmologist who can then get a better visual representation of the posterior portion of the eye and the retina. Nystagmus is almost always abnormal, so remember that. If you've got a nystagmus in a child, this is a sign of something more insidious. So the primary role of the primary care provider is basically to find problems here, right? We want to routinely do exams. We want to identify and refer as quick as possible. So we want to refer early and often. We want to be extra vigilant and maybe even a little hypervigilant at sending children to audiology or ophthalmology for common problems and concerns. So we want to refer early if we see these things in children. So cataracts, retinoblastoma, glaucoma, or a strabismus. So here's kind of the corrective measure for that. So the corrective measure for a retinoblastoma is surgery. The corrective treatment for glaucoma is going to be medications. For a strabismus, it's causing a refractive error in this case, and we can put them in glasses. If there's a difference between the two eyes, then we need to either do patching or surgery. We just basically want to take home that we're referring these children early to a specialist. So here are some of the treatment options that we see. So if this is a refractive esotropia, so his eye is going in, and it's because of the way the eye is processing light, and that this eye has a better ability to focus light than this. So what we do is we correct that with a lens that equals the two eyes, so that now this child is in a special lens, so that this lens is separate from this lens, and now the eyes are competing at the same level. We can also patch here. So if you've got an eye that's underperforming and it's easier for the child to use this good eye, then we actually patch the good eye and we have the child use the eye that is weak or that they are not using as much. And that will really kind of clear that up. So when do we refer? So we want to refer if there's any gross abnormalities, if they have abnormal reflexes, or there's an acute change in vision. If their vision is worse than 20/60, we want to refer. And for instance, if a child has visual acuity testing at the age of 3 with a left eye of 20/20 and the right eye of 20/100, we want to refer this, okay? So any gross deviation in their eye, like almost like as in growth charts, if the eye test was good a year ago and now it's completely off, we definitely want to refer. If we're seeing a trend, we want to refer, and if we're greater than 20/60, we want to refer as well. So here's some types of strabismus here. You've got esotropia, so the eye deviates inward, so esotropia, exotropia, hypertropia, and hypotropia. So those are kind of easy because they all follow that. I've also included this video that I would like you to paste into your browser and watch. This video does a really good job at demystifying amblyopia and explaining it much better than I can. But I think it's a really great video for you guys to get a little bit more information on these difficult concepts. And the thing is that these are really testable concepts, so we want to make sure that we understand them. So strabismus basically can progress to an amblyopia. So strabismus can also develop as a result of an accident or a health problem. Early diagnosis is essential in preventing any vision loss, and this occurs as a result of amblyopia, called a lazy eye. If amblyopia goes untreated, then it can cause a permanent strabismus. Occurs when the vision does not develop normally during childhood and this becomes chronic. So because the eyes are not aligned, you have a permanent strabismus. So go ahead and watch that video. That will be super helpful for you. Now let's go into ocular infections. These are probably the things that you'll see much more often. So this is, these are the ones, these are really the hallmarks that PANCE wants us to know. So we've got conjunctivitis, which is basically a just infection of the conjunctiva. So the scleral part of the eye, the white part of the eye, that cover over the eye becomes infected. We can see this in neonates and children. Most common is that going to be bacterial or viral? So just kind of think about that for a sec. We can have hyperacute, so just a very intense reaction, and we can have allergic reactions. So these are all the types of conjunctivitis. There's also dacryocystitis, which is a infection of the tear duct itself, and then periorbital or orbital cellulitis. So I would have to examine this patient to know, but this definitely looks concerning for either a periorbital or orbital cellulitis. So which is the most common? And I'm going to tell you right now, it's viral. Viral is very common. Although we do not, sometimes we'll just treat the patient because we're really giving them topical antibiotic. So, you know, I like to pick my battles. Treatment for a conjunctivitis that's bacterial is really just a topical antibiotic. So at times I will defer to giving them the topical antibiotic or have them do warm compresses for 24 to 48 hours. If it doesn't improve, then they have the prescription for the antibiotic rather than trying to pick that battle. I'm less likely to give systemic antibiotics if I'm not convinced that it's bacterial, but if we're talking about a topical eye drop antibiotic, then my threshold to treat them is much lower. All right, so conjunctivitis. So we've got symptoms of conjunctivitis include foreign body sensation, itching, burning, and photophobia. So you guys have probably all had pink eye or conjunctivitis. This is a really common, and you've probably all seen it. So the history for this is usually, you know, my child had a red eye, they went to bed, they woke up and their eyelids were matted together. That's kind of the hallmark of a bacterial conjunctivitis. So the inflammation can always vary in severity, right? You can have just some mild injection of the eye. You can have a little bit of tearing of the eye. You can have a subconjunctival hemorrhage. That's the hemorrhaging here of the conjunctiva. You can have some edema of the conjunctiva. You can have purulent discharge. You can also get these papillae or follicles in the conjunctiva itself. So, acute conjunctivitis of the neonate. So early on, we want to treat these children. They're just prophylactically treated at birth. So there's this early onset. So it's nice to know these kind of ranges because they're very testable. So gonorrhea is going to present within the first 24 to 48 hours. We're basically prophylactically treating these children with a topical antibiotic. But if this is a adult or an infant that wasn't treated prophylactically, like some child that was born at home, then maybe we could use IM ceftriaxone. So gonorrhea comes before chlamydia, so GC, I always remember that. Delayed onset with chlamydia, so we're talking 5 to 14 days. And the treatment is usually oral erythromycin. If we're suspected that it's a herpes simplex virus, then this is going to show up at about 6 to 14 days, so difficult to differentiate based on the history as far as chlamydia, but the presentation is going to be much different. So we want to see this child in the office and go from there. So diagnostics, we can do a gram stain, we can also culture it, and we can do PCR to get the genotype to effectively treat this. Prevention, so basically at birth, within 1 hour, we give these children topical erythromycin in their eyes, and that reduces the rate of both chlamydia and gonorrheal conjunctivitis. So these are not usually seen in children that are born in a hospital because they are prophylactically treated. Okay, so next we have bacterial conjunctivitis. This is an acute bacterial infection. You're going to have a lot of redness of that eye. You're going to maybe have some discharge, but it's going to be a purulent, thick kind of mucoid discharge like this one here. And that, I think, is probably a great picture of what it sounds like. And the parent is going to have this story, because sometimes they won't present like this. They'll have already cleaned it off or wiped it off, and so we want to listen to the story. What we're going to do for these children is give them some antibiotics. So they're topical antibiotics. So polymyxin B and trimethoprim is kind of the take home here. A lot of people prescribe this. Then there's a sulfa medication, tobramycin, and your fluoroquinolones. Fluoroquinolones we kind of reserve for the bad actors and people who wear contact lenses, because they're more prone to pseudomonal infections, and that's why we use fluoroquinolones. So when you give the erythromycin, this is how it's applied for these little guys. So the mother or father puts a bead of erythromycin ointment up under the eyelid, and then they, kind of blink that out, and it goes over the entire eye, and thus treats the infection. So it's usually multiple times per day, but you'll have to check your dosing for which kind of medication you're prescribing. Acute viral conjunctivitis, this is by far the most prevalent kind that we encounter in clinical practice. It often only affects one eye, and it's going to get worse at about halfway mark, which is about a week. But it can take anywhere from 2 weeks to more to resolve. So these parents usually come in at about day 5, and they want to know what the heck's going on. But generally there's this virus here, and the mucus and stuff can kind of clog this duct here that's supposed to drain the fluid into the nasal passage, and you get fluid back up, and it causes irritation. Also, the virus itself can just irritate the conjunctiva and cause this reddening of the conjunctiva. Okay, so that's kind of a common cause here. So we've got this itchy, irritated red eye without that history of purulent, thick, mucousy, stuck together eyelids. So we don't really want to use topical antibiotic here. I kind of gave you guys my soapbox on that. And steroids are contraindicated. So really it's just time and warm compresses for this. The most common here, the most common cause of these viral conjunctivitis is adenovirus. You can also see enterovirus. It can be seen in measles, and then HSV should also be suspected, especially if you have a good history for that. Here's your treatment. So cool compresses, artificial tears, warm compresses I've used too. It does make sense for a strictly acute viral conjunctivitis to use a cool compress, because it's going to kind of give you some relief and probably decrease inflammation. Artificial tears do help, and then when in doubt, cover this child for a bacterial infection. Hyperacute bacterial conjunctivitis, so this is a really bad one, right? So this is hyperacute. So obviously this is all this tissue here, the conjunctiva is completely hypertrophied, and this is a really disgusting eye. This is the eye that you want to get your culture on, and you want to plate that up so that you can see what you're dealing with, because if the first antibiotic you pick here is not effective, you're going to want to have some susceptibilities on hand. Okay, so etiology, these are, this marked injection, purulent drainage, there might be this pseudomembrane, just gross, right? So Pseudomonas is one of the bad actors here. It can be associated with contact lens wearers. We want to provide coverage for this, so we're going to put these people on ofloxacin, which is a fluoroquinolone, to help heal that. Okay, and we also want to ask if they if they wear contacts, right? So we don't want to forget to ask that question, do you wear contacts? Because then we need to put them on this fluoroquinolone to cover for Pseudomonas, right? Neisseria, gonorrhea, and meningitis can cause this as well. There is a risk of corneal perforation. You have all of this edema pushing against the cornea, and that's really the big risk here. Okay, allergic conjunctivitis. So allergic conjunctivitis, this is the lid. They've just kind of folded this lid down, and you can see this kind of cobblestoning like you do in the back of the throat with allergies. So I think that's kind of intuitive. But basically you have this histamine response. You get these inflammatory mediators that causes itching, edema, and watery discharge. And so that is one thing that's kind of a, you know, a lot of these people have that history of, you know, I've got allergies, or I was out in the smoke, or I was weeding my yard, or some sort of good story. So the treatment for this is cool compresses, artificial tears, topical antihistamine, and a mast cell stabilizer. Good luck getting that approved, but you know, if this patient has had recurrent infections, then we definitely could think about that. NSAIDs also help. Steroids, yes and no. We should always leave this to ophthalmology, as this is their wheelhouse, and we do not want to overstep our bounds, and we want to make sure that there's no other comorbidities that may cause them problems with use of steroid. So also extended use of glucosteroids with cataracts or can cause either glaucoma or cataracts in patients. So we're talking about putting a kid on long-term steroids. We definitely want to make sure that this is managed by ophthalmology before we do that. All right. So you'll see this cobblestoning, which we talked about already. They'll be red, and they'll be a good story for an allergic reaction. Dacrocystitis, so inflammation of the tear duct itself. A lot of times you're going to get that right here from like a blocked tear duct. You'll get some blockage here, and then the history will be, you know, my child has had, you know, this drainage and discharge, and maybe a light bit of erythema in the eye, to which the treatment is just these warm compresses and kind of milking down into the nasal passage to try and clear this lacrimal duct out. Okay, so the nasal lacrimal duct right here and there, and it should be draining. This child ended up with an infection, so now you've got this kind of paraorbital cellulitis, and definitely a cellulitis of the nasal lacrimal region here. And this treatment is going to be with antibiotic. So you're going to have erythema and edema over the nasal lacrimal sac. Your bad actors here is Staph aureus, Haemophilus influenza, and then strep pneumoniae. If this is a child and they're sick, right, so they've got, say, increased heart rate, low blood pressure, or they're febrile and young, then we want to admit them. Particularly under 90 days, these children's immune system is still progressing, so we want to be extra vigilant with these young kids. They'll go in for IV antibiotics, they'll get the full workup, and then possible surgical drainage here too. Preseptal and periorbital cellulitis. So that is a cellulitis of the orbital septum and the external skin around the eye. It is not back here in the orbit itself. So this can be caused by a sty from dacrocystitis, which we saw before. Can be a break in the skin where they get like a little tear here, and then you end up with an infectious process that does not go back into the capsule itself, but does stay here in the paraorbital region. Also can be referral from a dental abscess, and can be from a bloodstream infection. Orbital cellulitis is back here in the orbit. is a much more sick patient, and the real take home here is that they're going to have pain with extraocular eye movements. So if those are painful, we're suspicious of orbital cellulitis. We need to get a CT or MRI to confirm, and this patient's got to come in. So sinusitis is the most common cause of what badness? And the sinusitis is the most common cause of, think about it, meningitis. So meningitis is often caused by sinusitis because you've got the sinus passage here and your brain tissue is not too far away. So it can slip into the meninges very easily. There's not a lot of a distance to travel there. And the most common cause of sinusitis is the common cold. So let's differentiate between preseptal cellulitis and orbital cellulitis, right? So this is our bad actor. This is what we're worried about. These are kind of our common presentations, right? So preseptal or periorbital cellulitis, most commonly under the age of 5. There's 3 times more frequent than orbital infections. So you're going to see these a lot more, right? Here we've got broad range of presentation from year 1 to year 16. Greater in males than females, not sure why, and mostly in the winter months. So you've got this sinusitis or URI that then progresses to this orbital cellulitis. They're both due to Staph aureus, so you want to know the local MRSA pattern and what medications you need to choose. So what is a local MRSA pattern? We're going to talk about that. And then also group A strep and strep pneumo, which have been declining with vaccinations to these. So this is an antigram. So these are these biograms are developed in a certain locality, like a county health system, or the medical technologists or the microbiologists in a hospital institution will come up with these biograms that tell you the resistance and the susceptibility of the average gram, in this case, the gram-negative bacteria here. These MIC is the amount of medication required to inhibit growth of the organism. So here you can see that ampicillin, for instance, here's your antimicrobial agents. So ampicillin, cefoxitin, piperacillin, piptazo. Okay, these are all the agents that we use, and then you've got your MIC ratios. So the minimum inhibitory concentration required to stop growth of that bacteria. So with ampicillin, here's the MICs, okay? And then you've got carbamazepine, and then each different agent. So what these are alluding to is we'll go to the next page here, so this is how you calculate an MIC. So this is a minimum inhibitory concentration. So here's the concentration of drug, and it goes up, 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 up. You can calculate MICs based on how much antibiotic it takes to completely eradicate or stop the growth of the bug. You can see that, so like for instance, this medication here is much more effective at lower concentrations than this medication here. So this is going to have a lower MIC, and this is going to have a higher MIC. So you can see here, so Staph aureus, for instance, and then they used Cipro against it. Here's Staph aureus versus Levo. Here's a few different pathogens, and then where their MICs are. So it just kind of allows us to choose medications that are the best choice for the patient. And these are just susceptibility testing. What they do is they make a MIC, that's their breakpoint, and if they deem that that antibiotic is causing the organism to be inhibited, or that the organism is susceptible, then they will list that as susceptible. So sometimes you'll see S or R. R would be a resistant bacterium, and that's what you get back when you see your susceptibility testing. So definitely with sick babies or admitted patients, we want to get the susceptibility testing results. So preseptal or orbital cellulitis. Both can be unilateral. They can both cause islet erythema, swelling, warmth, tenderness, and may have fever. You need to differentiate these clinically. Okay, so preseptal diagnosis, preseptal orbital, preseptal cellulitis is a clinical diagnosis. There's often a story of trauma or some sort of foreign body or some sort of insult to the eye, and then they may have some slightly decreased vision or like weeping fluid in the eye that causes that, maybe a little bit of blurring of vision, but they can clear it. Their eye movements do not hurt, and the workup is usually just start them on an antibiotic. We may get a culture for a workup. An orbital cellulitis, they may also have blurry vision, but they're going to have, here it is, here's the hallmark of orbital cellulitis. No question about orbital cellulitis. Will not have this paralysis or pain with extraocular eye movements, right? They could have proptosis, so that just means the eye is bulging out because there's so much pressure behind the eye, pushing the eye out into the front, into the anterior portion. They can have chemosis, so swelling or edema of the conjunctiva. We want to CT these folks and see how deep that goes. And they're less likely to move their eyes. Why? Duh, because it hurts, so they don't want to move it. It's pretty straightforward. All right, so preseptal, there might be a predisposing factor that might determine our treatment, like if they are a contact lens wearer, but simple treatment, we're just going to do PO antibiotics. We can give the first dose IM. We're going to reevaluate in 24 hours to make sure that we're not dealing with orbital cellulitis, right? So we want to make sure that this patient is improving and that the antibiotic that we chose is the proper antibiotic. If it goes systemic, so it starts to move away from the eye, starts to present more like an orbital cellulitis, or they have systemic features such as fever or chills, right? Then we definitely want to admit these patients and put them on IV antibiotics. If it's orbital cellulitis, this is a bona fide admission. This patient's coming in for IV antibiotics. Once they significantly improve, we can switch them over to PO antibiotics. Okay, they may require a surgical incision and drainage, so they're going to have to go to a hospital that has access to an ophthalmologist. So how do we know which is which? Is this preseptal or orbital cellulitis? I don't know. We need to differentiate this clinically. So both of these children have what looks to be definitely periorbital, right? You can see the swelling here, see the swelling there. The only way to differentiate this is the child that has painful eye movements or the child that is reluctant to move their eye. And so this really is a clinical diagnosis. This could be an orbital cellulitis if she's unwilling to move this eye. Even though this looks worse, it could be periorbital if he's able to move the eye okay. So actually in this case, this gal, look, so here's her extraocular eye movements. See how this eye is not moving as much? So it's there and there. She doesn't want to move it because it hurts. Her gaze is inhibited, and she doesn't want to move it down as much either. So she's got this orbital cellulitis that's hiding behind here. She's going to be in remission for IV antibiotics. Next, we're going to move on to the ear and nose. So common cold. This is definitely kind of stuck in this chapter of ear, nose, and throat. Common colds are, well, common. We're going to see them a lot. How common? Well, the average child under the age of 5 is going to have 6 to 12 URIs per year. The symptoms last 7 to 10 days and really occur fall through spring. Now we're even seeing them in the summer. 30 to 40% are rhinoviruses. Then we have our coronaviruses, RSV, influenza, parainfluenza, adenovirus. These are normal viruses that we have co-evolved with over time. You know, the human body is colonized or infected by over 3 or exposed to over 3 trillion viruses at any time. Now with the coronavirus nuevo, we have to keep in mind that coronavirus has been around since about 3000 BC. So humans have co-evolved with coronavirus basically as long as we've been here. And there has been countless nuevo coronaviruses. We do see these a lot, although there is the newest strain seems to be particularly virulent, but this is a common virus and we have seen many new coronaviruses over time. So just keep that in mind. Common cold and URI, so you've got this good story, right? They've got a scratchy throat, they've got congestion, yellow or green discharge, their nasal secretions may become thicker and more purulent. After a couple days of shedding the epithelial cells, they could be tired, poor sleep, because when they're laying flat, they're having a cough. They could have or have not fever, cough, headache. The cough can linger for 2 to 3 weeks. So this is important to inform patients and parents that when they first come in, this could be there, okay? Unless there's a really bad fever or signs of pneumonia, this is just part of the process of a URI. So other physical exam findings: nasal discharge, redness, nasal oral mucosa, and anterior cervical lymphadenopathy. Cold management. So we want to make sure that these children are hydrated, right? So children have small lacrimal ducts, nasal lacrimal ducts. They also have small eustachian tubes that should drain the ear into the throat. So when they get backup of mucus, it's less likely to drain. And so these children are just like big mucus plugs. So their hydration helps to kind of thin some of the secretion and allow these secretions to drain. Gentle nasal saline suction, this nose Frida, you can actually suck the boogers out of your child's nose. It's totally disgusting, but if it works, it's worth it. A cool mist humidifier is always helpful to keep these sites kind of, moist and allow for drainage as well. Let's see, we've got honey, which is good for coughs, right? This can be used at greater than 12 months. We can worry about this with botulism toxin before 12 months. So after 12 months of age, they can use honey, they can use lozenges when it's probably about age 2. Menthol rub is really helpful to help with congestion, ibuprofen and Tylenol. And then there's a dosing charts that we should provide for parents, particularly for younger kids, as a lot of these ibuprofen, Tylenol medications say ask your primary care provider for dosing information. I like to abstain from decongestant and cough meds, especially before the age of 6. Children have higher incidence of pneumonia when they are given antitussives. The cough reflex itself protects the lower airway from pathogens, and so when we suppress coughs in kids, they end up with pneumonia down in the lungs, so we want to be careful with that. So the real thing that we have to differentiate is it a common cold or is it more than a common cold? So a common cold is generally viral. It's generally self-limiting and may have a fever in the first few days, but then the fever usually kind of subsides. You may have this lingering cough for even up to 3 weeks. So we need to let parents know that lingering cough is normal, even up to 3 weeks. You know, if there's no other findings consistent with pneumonia, if they're not having recurrent new fever, then we can give them some reassurance. So the most common cause of sinusitis in kids is caused by the common cold. Here's part of the reason. They've got these tiny little tubes, the eustachian tube, even their sinuses are a little bit squashed in there, and the lacrimal duct is also even smaller. So children just have small ducts. So they end up with bacterial infections behind that blocked duct, like an otitis media. So otitis media, sinusitis, often caused by a common cold sequelae, right? So they've got this small eustachian tube, get inflammation, you have eustachian tube dysfunction, so the tube becomes blocked, and then you have a negative pressure that kind of sucks the bacteria into this ear, causing infection. So movement in viruses and pathologic bacteria from the nasopharynx into the middle ear. So they can also come into the ear by that negative pressure. So just something to keep in mind. Okay, acute otitis media guidelines. So these are the guidelines. So in otherwise healthy children with no underlying medical conditions, if they're from 6 months to 12 months, 12 years of age, we can diagnose it clinically, and the management is pain control, observation versus antibiotics. So what they're doing right now is if it's a unilateral infection, so it's just one ear that's infected and the other ear is normal, what they're doing is they're saying, let's defer treatment because this is self-limiting. There's no infection on this. That's a tough sell to a lot of parents. So sometimes what I'll do is give them the antibiotic and let them know that if the child does not improve in the next 48 hours that they can initiate an antibiotic, or I'll have them check up and have a close follow-up that is helpful to reduce antibiotic use. So how do we diagnose this? Well, it's usually an acute onset of symptoms. In older children, it may be a rapid onset of ear pain. If they're not verbal yet, they may be tugging at their ears, holding their ears, crying, or behaving kind of out of character. They may also have difficulty sleeping. So we've got some signs here. They're going to have effusion. They're going to have inflammation. They can have a bulging tympanic membrane. And what we utilize here is the pneumatic otoscopy or tympanometry. And what that's looking at is to see if the eardrum itself is still mobile. Because if there's fluid built up behind the eardrum, then the eardrum can't. So this is what the normal middle ear looks like, and the eardrum moves to transmit sound. If there is an infection here, then the eardrum is rigid, and we can see that with some of this testing here. You could also see a rupture of the tympanic membrane. So the tympanic membrane is bulging and infected, and then you see this perforation here, and you've got blood and pus that spews out into the canal, and that's called a perforation. With those children, we want to put them on antibiotics for the ear infection. Then we also want to treat them with the drops so they don't end up with the worsening of the infection. So physical exams can be difficult with kids. I like to have the parent hold the child, just like as in this video. You can also have the parent hold the child's head so that they're facing the mother's chest, and then look in one ear and then the other. It really does help to have a good parent because it's difficult to restrain these children. Much easier if the mom or dad holds them. It's difficult to use the pneumatic bulb, especially with kids, and you want to make sure you have an airtight seal, because that pneumatic bulb, you're blowing air into the canal and you're watching to see if that tympanic membrane moves. If you're not having a tight seal, then you're going to get a false positive. So we just want to make sure that we have good equipment. We want to remove any wax that might be in the ear canal so that we can visualize the tympanic membrane. Some other problems, factors that hamper the physical exam are clinician inexperience. So you should look in every person's ear that you can, even if they come in for a stub toe and you're in your clinical rotations, you should look in their ear because there's a lot of variation of normal. So we need to see all the normals so that when we get an abnormal, we can better differentiate between variations of normal and abnormal. So here's a normal ear exam. So you've kind of got this coating here. It's this translucent membrane. And then on the inside, you can see the bones, okay? So this is a normal ear. This is a normal ear with some inflammation on it. So there's a little bit of erythema around the tympanic membrane. So when we talk about our ear exam, we want to describe the contour, the color, the translucency, the mobility, and the landmarks. So a normal exam looks like this: normal, pink, pale, pearly gray, translucent tympanic membrane with a good light reflex, normal bony landmarks, and normal mobility. So that's a normal. So here we go again, just kind of, we want to investigate the contour. So is it normal? You know, is it a normal tympanic membrane? Is it a, there's the inner canal and the outer canal, okay? Is it a retracted tympanic membrane? So is it retracted? Is it bulging or just full of some sort of fluid? And then we want to talk about the color. You know, is it gray? That's kind of normal, yellow, pink, red, or this kind of amber color, like a little bit darker than my pointer there. Translucent, is it translucent? Can I see right through it? Or is it opaque and I can't see through it? Okay. The mobility, normal. So it's going to be able to flex a little bit with normal mobility, outward with negative pressure. So as I create a negative pressure with that bulb, the tympanic membrane comes out, and then as I push in, it's going to go back in. So I want to note if this is normal, decreased, increased, or absent. Bony landmarks are basically going to be the malleolus here, malleolus, right there, okay? And that's basically what you see on the tympanic membrane, just kind of this white structure behind this gray membrane. All right, so here's kind of the template for a normal ENT exam. So you've got your constitutional, right, and then you've got their eyes. So pupils are equal and reactive to regular light and accommodation, so that could be an A at the end also. The conjunctiva is moist, there's no injection, the movements are normal and pain-free. And then you go into the ears. So this is just a normal exam, right? So non-tender tip manipulation of the pinna and the tragus. The canal is clear, the tympanic membrane is pearly gray and non-bulging. And then you can go into the duration of that exam, which I will let you look at in your own time. So here is some tympanic membranes that I want you guys to be able to describe with words. This is the pneumatic, that's the pneumatic bulb that you use to check for the mobility of the tympanic membrane. And I will just give these to you to write a description of. I want you to be able to describe that, but I will just loosely describe it. This is an infected purulent ear, and this is an effusion that is a what they call a serous effusion. This is a suppurative infection. So go ahead and do a little research and have some good descriptions of that, because that's what you're going to be doing come next year. There's acute otitis media, and there's a serous otitis. Okay, so middle ear signs. So we want to basically talk about inflammation and effusions here. So this is kind of the progression of an ear infection. So you start with this tympanic membrane that's translucent, and you can see the bony prominences behind it, and then you start to get this effusion, so that's swelling, right? Now you've got purulence to it, and now you've really got this bulging, vascularized, irritated eardrum. This patient hurts, right? So our management, we want to assess if we need something to treat pain, we will give that to them. We want to make sure that they're tolerating PO food and fluid, that they don't have a stiff neck or any signs of meningitis when we're assessing for a bad ear infection. The mainstays are going to be pain relievers. Also, topical benzocaine has been utilized for pain in the ear, but now it's not any longer approved by the FDA. So patients will often ask for this, but now we really cannot help them very much. Tramadol is effective. We don't like to use codeine in children because of respiratory suppression. So that thing I was talking about, increasing their risk of pneumonia. We can also cause these children to have altered mental status as well with codeine. And then there's a naturopathic kind of topical that can be used above the age of 6. So, for severe otitis media, we are going to treat these children with antibiotics. If they have severe signs or symptoms or systemic features, we definitely want to treat these children aggressively. If there is non-severe bilateral otitis media and they're younger than 24 months, we can give them some antibiotics as well. If it's a non-severe unilateral and the child is younger than is greater than 6 months, or a non-severe otitis media in an older child, we can kind of do this shared decision-making with the caregiver. What we can do is discuss kind of the pros and cons of the antibiotic, and we can have them observe them for 48 to 72 hours. And if they're not getting better, then they can initiate treatment. So I usually discuss with this the patients and the parents, and they generally are happy with that plan and happy to have the antibiotic in case they need it. So microbiology, the most common bacteria that causes infections of the ear is strep pneumoniae, so 35 to 40% of cases. There's also Haemophilus influenza, which is non-typable. It needs to be, to grow Haemophilus, you put it on a chocolate agar plate. So sometimes when we do culture and ear culture, there is a chocolate plate included, and then they can extract Haemophilus influenza. And then MOCA, Moraxella catarrhalis, causes about 15 to 20%. So this is really interesting. So 19 to 48% of these infections will clear with no antibiotics at all. So which antibiotic do we want to use? Generally, well tolerated by children and very safe, been used for a long time. So we tend to steer toward high dose amoxicillin. So 80 to 90 milligrams per kilogram per day, divided in 2 to 3 doses. Now, when we reach adult dosing, then that's where we stop. So if the child exceeds a dose of 500 milligrams per dose, that's the highest dose they get. So say that their dosing for the day is 3,000 milligrams. Well, they're going to get 500 milligrams 3 times a day, and that's the maximum dose per day for that child. Also, if they're refractive, they don't respond to amoxicillin, then we can use amoxiclav, which is augmentin and is going to increase the coverage and also provide beta-lactamase inhibition here. So amoxicillin use in the past 30 days, this is a reason to use augmentin. Co-current conjunctivitis is a reason to use augmentin, and recurrent otitis media that is not responsive to amoxicillin is a reason for augmentin. If you do start a child on augmentin, you want to make sure that the parent knows that the child can get diarrhea. This is not a side effect of the medication, it's just an effect of the medication wiping out your normal bacterial flora, in which case after they complete the antibiotic regimen, they should be treated with a probiotic so that they can reestablish that healthy flora. Alternative antibiotics are your cephalosporins, further generation down, so cefdinir and cefuroxime. These are all PO antibiotics. You can also do ceftriaxone IM for these patients as well. Here's an up-to-date graph on choices of antibiotics for treatment in otitis media of children. Up-to-date is a great resource that you should be currently using, and if you're not, you need to get with the program. All right, so clinical course. So otitis media, by 48 to 70 hours, they should have a decrease in their pain level. They should be not having a fever anymore. And definitely with children, we always want to look at their appetite. Where's their appetite? How's their appetite? Are they sleeping better? And are they acting normal, right? That's a big thing with kids, is always behavior. If this is a viral infection or a resistant bacteria, they may not be improving, and the symptoms may carry on. If it's severe and it appears to not be a viral infectious process and there's systemic features, then we want to jump to our augmentin. So say that we were at Amox, now we go to either augmentin or a third generation cephalosporin. It's always fine really to choose either clinically, but cost-wise, these third generation cefepines are really expensive. So sometimes insurances won't cover them or the patient can't afford them. So augmentin is a good choice, and you can always consider IM ceftriaxone at about day 3 if they're not improving, and then follow it with one of these 2 medications. At the follow-up visit, we need to recheck those ears, right? I like to do a 7 to 10 day follow-up. So the normal course of these antibiotics is usually about 10 days. You can get away with 7 as long as you look at their ears and their symptoms have resolved and the signs have resolved as well. Young children may have more severe symptoms and may have a recurrence, so that may be an indication to refer these children to a pediatric ENT. Middle ear effusions, the success rate after treatment, so at 2 weeks, about 60 to 70% are going to resolve. At 1 month, 40% are resolved, and at 3 months, 10 to 25% resolve. So middle ear effusion after successful treatment. So if you've got an effusion like a serous effusion, if it's not improving within the first couple of weeks, we want to think about sending these kids out because they may need tubes, because the longer they go, the less likely it is to resolve. So if we've got like the serous effusion, but it's not infected, we can put the children on some second generation antihistamines to help decrease inflammation and allow the eustachian tube to drain successfully. We want to increase their water intake, and then we probably want to get a referral in if we do a recheck in 2 weeks and they're not having improvement. So here's some follow-up exam findings. So if we've still got this, right, we need to up our ante with a better antibiotic because we still have a suppurative effusion. Here we've got what's called an air effusion, okay? So there's air in here. This is also called a serous effusion. And then here you've got a retracted tympanic membrane, so you can't really see it, but the membrane's actually going back like this. If you're looking down this canal, and this is their ear, and here you're looking down it, well, you see this membrane, instead of being like this or slightly like that, it's retracted, so it's pushed back. And this is also scarred, and you can see here, this is a part where they had previously blown out their eardrum, so this is a scarred eardrum. So here is the tympanometry. It evaluates for mobility of the tympanic membrane. A normal tympanic membrane is going to move away and then back. So that's what this kind of peak here at 0 is telling you, that it's doing this. And then if there's no mobility, there's so much fluid that it can't move, or it's perforated, so it's just allowing air to go in and out. Then you get kind of this flat slope. So this kind of wimpy graft. And then if it's mobile but retracted, then you're still going to have this peak look because it's moving, but it's going to be a little bit farther down the canal, and so you see it more toward the negative. So if we see a retracted membrane here, it's going to land on this side of your tympanometry. But the take home really here is if there's no movement, we got a flat one, the peak is normal. So we need to refer to audiology, especially if they've had this persistent middle ear effusion for greater than 3 months. We've got to refer to ENT, and then we've also got to refer to audiology because they're going to have conductive hearing loss. Recurrent, about 50% of kids are going to have these recurrent infections. Don't beat yourself up for it. It's not your fault. Just send them to ENT so that they can get proper workup and maybe even tubes. Some risk factors is, you know, winter, men or boys for whatever reason, and then smoke exposure. Prophylactic antibiotics show minimal benefit. They're not really decreasing the rate of infectious process, so they're really no longer recommended, and we are breeding bacterial resistance by doing that. The current recommendation is to offer tubes to these kids. So 3 episodes in greater than 6 months is an indication for tubes, or 4 episodes in a year is also an indication. So this is an ENT referral, right? Just send them out, get them worked up by ENT. So here's what these tubes look like. So sometimes they're green or they're white, but you'll see them. And that's just allowing the ear to drain properly and not harbor infection. So we also want to make sure that we're referring these kids for audiology because they are, if they've got this middle ear effusion, they've got conductive hearing loss. Once they get tubes, some of them are going to have tympanosclerosis. So sometimes you'll see this kind of scar look on that other ear. Before there was a scar like right here. When this tube comes out, then the ear will repair itself, but you're always kind of having this white kind of half moon shape there that is indicative of a previous scar. Chronic perforation, so they may just have a tympanic membrane that chronically has a perforation in it. The risk for that is pretty low with short-term tubes, but when they have tubes longer term, the risk goes up significantly. So yeah, here's a tube here, and then here's a chronic perforation, and then you can see all this scarring. So this white is scarring of the ear itself. So evidence-based for prevention of acute otitis media is the pneumococcal vaccine. Influenza vaccine is always a good plan for these, and exclusive breastfeeding till 4-6 months, because mom's going to give the baby the antibodies. The baby will be less likely to suffer from some of these bad pathogens because they've already got a functioning immune system when they're young. We also want to avoid exposure to tobacco and smoke. Avoid bottle propping, as this can cause kind of flow back into the ear canal or into the eustachian tube, and increase their water intake, particularly with older kids over 1 year old, or when they're already on solid foods at about 2+, to help thin the secretions and cause less backup. Reduce pacifier use after 6 months. So that kind of causes this negative pressure when you're chronically sucking on that, and it can increase the risk of acute otitis media. Mastoiditis, so this is a really bad actor. Basically, mastoiditis is you get some sort of an ear infection, and then this entire mastoid bone gets infected as well. It's usually warm and hot back here behind the ear. So the mastoid air cells are usually inflamed. The mastoiditis usually is a complication of acute otitis media. And typically they're less than 10 years of age. Most common is less than 2 years of age. So these are little guys. So we want to be really careful with this because it's very close to the meninges. And so we really want to worry about that if we see that. That is probably an admission, definitely a call to a pediatric specialist. So preceding otitis media, this is kind of the presentation. They're going to have this otitis media. They're going to present with pain behind the ear. It's going to be hot, it's going to be swollen, and it's going to be tender over the mastoid. You can also have some outward displacement of the pinna because of that swelling. They're going to be sick, right? These people are sick. So they've got fever, ear pain, headache, hearing loss, rhinorrhea, ruptured tympanic membrane. These people are sick. Don't miss this. So what we're going to do for them, we're going to CT scan them. So the CT scan shows inflammation, infection of this mastoid here. This is air, okay? This is infection. So there's that infection there. And you can also see even this lymphadenopathy and some swelling adjacent to the affected ear. IV antibiotics, we're going to admit this patient and we need ENT to consult on this case. If they do a myringotomy, that means they go in there and they're going to extract some of the fluid and they can culture that so that we can aid in treatment properly. IV antibiotics and then tympanostomy tubes will probably be placed. The child will leave with PO antibiotics and otic drops until the drainage clears. So let's talk about just some common infectious process in the pediatric patient. So we've got common cold, fever for 1 to 3 days, nasal discharge that starts as clear and watery, then thicker and mucoid, and then colored and opaque. So it kind of follows, I mean, we've all had the common cold, right? We understand how that goes. Usually it's going to improve in 10 days, but we need to caution parents that it can be up to 3 weeks. Sinusitis. So the common cold can definitely cause sinusitis. So the most common are ethmoid and maxillary sinusitis. You're going to have some air that can get back in those sinuses. In the maxillary at about air, these are going to develop at about 4 years, the sphenoid at 5 years, and the frontal begin to develop at 7 years. So the ethmoid and maxillary are present at birth. The other sinuses are slowly going to be, they're present, but they're not full of air yet. So that's kind of their progression there. So here's the front view. So you got frontal sinuses, the ethmoid sinuses, and the maxillary sinus. This is a side view of the same. So frontal, ethmoid kind of here, and then you got your sphenoid sinus and maxillary sinuses. So paranasal sinus mucosa is continuous throughout the nose and nasal pharynx. Cilia moves secretions through the sinuses and down out of that space. Sinuses are normally sterile, but nose and nasopharynx are heavily colonized with bacteria that protect against infection. So the pathogenesis of sinusitis is usually it starts with a cold. You've got this negative pressure from all the mucus and junk, and it draws pathogens back into the sinus and then doesn't let them back out. This can be caused also by loss of the functional cilia. So this is why we talk about smoking being a risk factor, right? So smoking damages those cilia and can cause increased risk of badness and increased risks of some of these sequelae of the common cold. Thickening of secretions, that's why we always want to increase fluid intake, and there can be a buildup of fluid and mucus, which is a great medium for bacterial growth. Acute bacterial sinusitis, so the most common presentation is persistent symptoms, greater than 10 but less than 30 days. You're going to have this clear, watery, mucoid, purulent discharge. They may have malodorous breath. They may have a cough that's worse at night or a low-grade fever. Less common is the acute onset of fever with purulent rhinorrhea, greater than 4 days usually, with a URI fever, and then it's going to decrease in 1 to 3 days after that. Older kids may have face or teeth pain. Acute bacterial sinusitis, so now we're talking about an actual bacterial sinusitis, not a viral. We're going to see this on physical exam. It's going to look similar to URI, but they're not going to have, they're going to have a history or a lot of pressure when they bend over. There might be mucopurulent drainage. There also can be kind of this, when you look up at the nasal turbinates, you can see this erythematous kind of boggy, they call it, pale mucosa that it just looks like filled with fluid. That would be the boggy, would be more of a edematous nasal mucosa. Sometimes you'll see swelling, discoloration in the eyelids, so they might have kind of pooched up eyes. They might have sinus pain. They could have a history of recurrent otitis media. Diagnosis is usually clinical. We don't really image these kids. We want to save them the radiation, especially if it's not complicated by systemic features. So there is some utility to microbiology. The hard part is that we might, if we just swab these kids, we're going to get a sample that shows us what their flora is, and we might actually misdiagnose it here. So the only reliable sample is a sinus aspirate. Since the middle ear cavity is a paranasal sinus, data from the middle ear aspirates is used to recommend treatment. So if you have a middle ear aspirate, you can assume that that's the pathogen in the sinuses as well. So treatment, we're going to do high dose amoxicillin clavulanic acid, so that's Augmentin at 90 milligrams per kilogram per day. Second line is going to be your second and third generation cephalosporins. If it's a severe case, then we want to put them on a quinolone, and we're going to have to hospitalize these children if they appear toxic or have systemic features. Azithromycin is also a healthy choice, although we have been getting some resistance, so both azithromycin and Bactrim have really been, the use has been derailed over the past few years. If you do treat with azithromycin, generally for adults, I'll treat with 500 azithromycin daily for 5 days. And that generally is good practice for adults because the Z-Pack is 500 and then 250. But with children, if you have to, based on allergies, then you can use azithromycin, but you want to dose it probably at the higher end of the dosing range. So the course is that their symptoms should decrease within 48 hours, and total treatment lasts about 10 days. If there's a slower response, then treat until they're asymptomatic for 7 days. Complications, so it can spread to the orbits. You can get an orbital cellulitis or a paraorbital cellulitis. It can also spread to the meninges, which is bad juju. So we want to watch for that. We always want to document that they have no nuchal rigidity, that they have no abnormal bleeding or bruising, which are all signs of meningitis. If they have recurrent sinusitis, then it's typically due to a recurrent URI, or the child is in childcare. We need to know that 5 to 6 of these per year is normal. So don't overreact if the child's mother has the history of, or father has a history of the child's got 6 infections this year and that they're worried. That's good to reassure them that is normal. They recurrent sinusitis risk factors are going to be allergic rhinitis, tobacco smoke exposure, gastric reflux, cystic fibrosis, immunodeficiency disorders, and then ciliary dyskinesia, right? So that's, these guys kind of go hand in hand. So persistent rhinitis, if it's not a URI or sinusitis, what else could it be? Well, it just depends. If the history is that it's acute and it's green and it's foul smelling and it just came on, then we've got to be a little bit more concerned for maybe like a foreign body. If it's not, and it's been chronic, then we can definitely consider allergies as a cause. So if it's unilateral and smelly, we do not want to consider that normal. So here's your foreign body. These are going to be a mainstay in emergency departments. So this child has put a bead into his nose. They're going to have this unilateral foul-smelling rhinorrhea. Sometimes children will put something up in their nose and the parents don't even know it, but what they see is this drainage and stinky unilateral nasal drainage. So it can be, allergic rhinitis can be, if it's non-infectious, right? It can be associated with large adenoids, nasal polyps, foreign bodies. If it's non-allergic or vasomotor rhinitis, it can be caused by irritants, cold air, spicy food, or cocaine use, which we hope none of our children are using that. Uncommon would be medicamentosa, right? So that's actually rebound from using decongestants too much, which we probably shouldn't see that in kids, but we do want to keep that on our radar. Also, eosinophil syndrome, if they have persistent elevated eosinophil count in the blood for greater than 6 months, we can suspect this without the presence of a parasitic infection. So allergic rhinitis, this is triggered usually by IgE antibody. It's going to release leukotrienes, cytokines, prostaglandins. Then they get this, right, nasal congestion. Histamine is also released, which causes sneezing and itching. Want to understand this physiology so that you can explain it to your patient. And this is why we use the medications that we use. So the newest classification for allergic rhinitis is if it's intermittent, that means less than 4 days per week, or less than 4 weeks, that's intermittent allergic rhinitis. If it's persistent allergic rhinitis, then it's greater than 4 days for greater than 4 weeks. Old terminology was seasonal and perennial. Now we're using intermittent and persistent. So here's the mechanism of action. And you would basically want to understand how this works. So histamine is going to, so the mast cell releases histamine. Histamine targets these histamine receptors that then trigger a cascade of reactions that cause basically inflammation and increased mucus production. So when we give somebody an antihistamine, the antihistamine goes and blocks this target receptor so that the histamine can't bind and elicit a sequelae of reactions. So good history for allergic rhinitis is, mouth breathing, snoring, nasal voice, irritation, secondary to maybe exposure to allergens. They can have sneezing episodes. They might have an itchy nose. They might have that allergic salute, which will look, it's kind of a line here because they do that all the time. They can have itchy eyes, a post-nasal drip, headaches, sleep disturbance, fatigue, impaired concentration. It can be seasonal. It can have triggers. And there can be some alleviating factors here. We basically want to help these children so that they don't have a miserable existence, because this is not fun. Comorbidities. So a lot of times allergic rhinitis can cause clogging of that eustachian tube, and therefore you end up with these increased middle ear infections. Sinusitis is also another sequelae of allergic rhinitis. Asthma, so there's this triad, right, with children. So the triad is asthma, eczema, and allergies. Okay, that's the allergic triad for kids. Asthma, allergies, and eczema. So about 1/3 of children who have asthma also have allergic rhinitis. Atopy, so genetic relation to developing allergic rhinitis. So here's your triad: allergic rhinitis, asthma, atopic dermatitis. So there's that triad. They may have poor school performance. The symptoms may be distracting to them. And sometimes if they're put on a sedating antihistamine, man, they're going to be snowed. So it's tough to concentrate in school if you're on Benadryl. Another thing that you might see on these kids is these allergic shiners. So you kind of see this darkening there. And then here's the allergic salute there because they're doing that number. So that's a transverse nasal crease, and then the allergic shiners. The posterior oral pharynx, you can see some cobblestoning. And these allergic facies are these kind of elongated face, open mouth, rescinding chin, overbite, and arched hard palate. Here's the cobblestoning. You can see that kind of shiny cobblestone appearance to the posterior pharynx. Diagnosis, we want to get a good history. We want to get a good physical. We want to make sure there's no hypersensitivity, right? That's the money shot right there. If so, we need to cover these kids with some sort of an EpiPen. We can do a nasal smear for eosinophils. Never done one in practice, but if this is a persistent problem, then we may want to do that. We also may want to defer to ENT. We can do some skin testing, and we're probably going to refer these to an allergy specialist. Serum tests need to be clinically correlated. However, serum tests are a little bit difficult because lots of times if they think they have an allergy, then they're keeping those allergens away from the child. So the way that the body works is you're not going to see that antibody in the blood because the child has not been exposed to those allergens. So you can get false negatives. You can also get positives that they'll say this child always eats, eggs and has never had a problem with them. But then they come up with an egg allergy on their panel. So take those with a grain of salt. You want to defer usually before doing allergy testing because it's expensive. And it can really be a difficult conversation to have with a patient if you get some equivocal results, which tend to happen quite normally. So obviously avoidance, right? We need to avoid the triggers, avoid pollen during high pollen times, which is usually in the morning. Use a good filtration system for your home. This is allergy control medication during this pollen season. You want to use a dehumidifier if you have mold, if you have a allergy to mold. Dust mites can also cause that, so constantly changing pillows and bed coverings, washing linens, hot water. Pets also can cause, the dander from the pets can cause allergies in some children, so we want to at least keep them maybe from sleeping with the child or the child really rubbing their face on the kitty or something like that, and that will decrease the exposure to dander. These pets are considered reservoirs. Also are these fomites too, so like the pillows, the upholstery rugs, those are all kind of fomites that hold on to that dander and can make it worse. So what do we do with medications? So we're going to use intranasal steroids. That's the mainstay of treatment. So your Flonase nasal spray. A lot of people will use it PRN. They are still the most effective, even if they're only used PRN, but they're definitely best if they're used long-term, as what it does is it inhibits the younger white blood cells from dumping histamine and other incendiary compounds. And the more young white blood cells that we inhibit, the more effective. So after 2 or 3 months, the medication is very effective. The compliance is really poor. So we want to educate patients on how this medication works and that they have to use it long-term to really see the benefits. It doesn't taste very good. You're spraying something up your nose. So children are oftentimes not very good at compliance with this medication. So we have to keep that in mind also. Antihistamines are great. They decrease sneezing, runny nose, itching of eyes, but not nasal congestion. So that's where maybe we'll use a saline wash if they're not tolerating the Flonase or the intranasal corticosteroid. We want to use non-sedating medications during the day, like a second-generation antihistamine, and we can use Benadryl and things like that at night if those are needed. Also, montelukast is a leukotriene inhibitor, so it inhibits leukotrienes from causing inflammation and reaction. The modest benefit is seen, and they're also used in asthma, but they're very expensive and difficult to get covered. Other management, so we can use oral decongestants. These are not recommended in children. They have stimulatory effects. They can cause cardiac issues, and they can generally just whack these kids out, so we don't really use them. Topical decongestants, there's very narrow safety margin for infants, but in older children, we can occasionally use short-term. We want to caution them with rebound nasal congestion because that is just terrible. These are like Afrin and Mucinex, so these are used in very limited amount, maybe a max of 72 hours with these, okay? It's beautiful writing. And then immunotherapy, so if they failed all the others and they have some money to spend, then you can do some immunomodulator therapy. These people should probably be referred by this time to a specialist. Otitis externa. So otitis externa is an infection in the canal of the ear. Peak in summer because kids are swimming, they get water stuck in there and they get an infection. Otitis externa is primarily caused by Pseudomonas aeruginosa, but can also be caused by Staph aureus. Fungal infections are uncommon, particularly in healthy children. They may have little micro fissures. So see how this eczema is causing these little cracks? Well, that's also occurring in the ear canal itself. And that's a place where bacteria can get in there and cause an infection. So 90% of otitis externa is caused by these two bad actors. So we can treat this pretty easily. If it's a rapid onset, which it generally is, it's going to have drainage from the ear and pain. It's going to hurt when you move the pinna or you press on the tragus, and there's going to be a good story with it. There may be some erythema and edema of the canal. You can really see the swelling in this canal here. Look, this canal is just virtually closed. And so in that case, we insert an earwick, which is kind of like a little tampon that goes in there. It impregnates with antibiotic as you put the drops in, and then it allows for us to treat this infection and get the medicine where we need it. So what else can cause ear drainage? Well, if there was a trauma involved, we really got to worry about cranial fracture. So basal or skull fracture can cause CSF to leak, so that's always on our differential. But if there's no sign of trauma and no history of trauma, then we can kind of be less vigilant about that, but we should always keep that in the back of our mind. If they've got a purulent drainage, it could be an otitis media with perforation. They could also have mastoiditis or a brain abscess, so we got to keep that in mind. Less pain, you know, it could be an otitis media and then it perfed. So otitis media tends to just bulge and bulge and bulge, and then once it perforates, you get this little perforation, and all that pressure resolves, and now the membrane's like this with your little perforation, and it doesn't hurt as much anymore. You can have a foreign body. You can have furunculosis, which is an infection deep within a hair follicle. You can have a traumatic tympanic membrane rupture if there's trauma. You could have blood coming out of that tympanic membrane or canal. So otitis externa treatment. So primarily we want to manage their pain with Tylenol or ibuprofen. We're going to put them on a fluoroquinolone, so ofloxacin otic, and that's 5 drops either 2 times a day or 10 drops daily. for a max of 10 days. They need to lay on the unaffected side. The drops go here. They watch a YouTube video or whatever for 5 minutes so that it can pool into their ear. And then they usually resolve very well. I do encourage parents to set a timer, because when you're laying on your side with a sore ear and drops in it, 5 minutes feels like a really long time. So there's the drops right there. No swimming, so we want to keep these kids out of the pool, and we also want to keep the ear dry. The parent should be able to administer the medication. May want to talk to them about it. And here's a little bit. An earwick is used if needed. If we've got that really tight canal and we know the medicine's not going to go all the way into the canal. So if here's the ear, you've got the canal here. If this canal is so swollen that you can't get anything in, then what you do is you insert an earwick in here. And what the earwick will do is insert it down like that. And then you put your drops on, and the earwick sucks them up and then allows that medicine to diffuse into the surrounding tissue and repair that infection. So prevention for otitis externa is to keep the ears dry, maybe use some sort of a ear plug so that they don't get water in the ear. They can also drain the water. We've all done that, right? Or use a setting like a hair dryer on a low setting. If it's recurrent, they can use a 1-to-1 alcohol to vinegar ratio solution before and after swimming at night before they go to bed. So let's talk about oral diseases and dental caries. So 1 in 7 children ages 2 to 8 has untreated caries in their primary teeth. So primary teeth mean that these are some of the teeth that they have just gotten. So these teeth are the teeth that they want to keep for good, right? So we want to keep these teeth nice and healthy. Here's some signs of early decay. You can also see the white right here. This is plaque buildup and starting to break down the enamel. Chronic infectious disease is one of the results of chronic dental caries. The chief bad actor here is Streptococcus mutans, is vertically transmitted from mother to infant. So let's look at these early childhood carie risks. So increased risk with poor dental care, frequent feeding, bottle propping, carcinogenic foods, or household with caries, right? So if your parents don't take good care of their teeth, you're probably not going to take good care of your teeth. Decreases with, obviously, cleaning your teeth, using water between meals and not like juices and things like that. If they use a cup at the age of 6 as opposed to a bottle, that's helpful. And then regular fluoride treatments or fluoride-based toothpaste. So when we're teaching children to brush their teeth, they only need a pea-sized amount of fluoride-rich toothpaste. And children over 3 are able to spit, so they can do that on their own, and they can use the fluoride toothpaste. So topical fluoride inhibits demineralization and bacterial metabolism and enhances remineralization of the enamel of the teeth. Systemically, it reduces enamel solubility. Fluoride sources include toothpaste, varnish, and rinses. Water fluoridation has really helped with this. Dietary supplements. Well water is variable because it might not be treated with fluoride, so those individuals may need to use fluoride-rich toothpaste or a supplement. Fluorosis, so this is chronic excess of fluoride, so greater than 0.06 milligrams per kilogram per day during tooth development. So this would be those primary teeth that we talked about earlier. And topical varnish is associated with fluorosis. This is intermittent. So intermittently putting topical fluoride on the teeth is not going to cause fluorosis. This is just when we have chronic excess oral intake of fluoride, we can get these fluorosis, which cause these white streaks in the teeth and deposits of fluoride all over the teeth, which is pretty gross. Oral candidiasis, also known as thrush. So this is baby bottle thrush here. Occurs in young infants, may occur in older, healthy children, but also in immunodeficient children or children that had previously used antibiotics or have diabetes. But you're going to see these white plaques. KOH prep is going to look like this. You do not have to do this to diagnose, but it might be helpful if you're trying to differentiate it. But you'll see this yeast and bud kind of pattern, and this helps to differentiate if it's yeast or some other bad actor. Candida albicans is the chief yeast here, and it's fairly common. A good way to prevent that is basically sterilizing the bottles and sterilizing the pacifiers. Also, if mom is breastfeeding, you need to treat the mother. So the treatment is a topical nystatin suspension to the mouth. Also, there's a one-time dose of this Gentin violet, which turns their mouth this really purple color, but is highly effective at eradicating the rash. The history of this is probably going to be that the child is not feeding very well. And so that's when you really want to do a good exam of the mouth. These kids are not easy to examine. They're not going to want you to put a tongue depressor in their mouth. But if you're concerned about it, you need to go there and find out. This is the Gentin violet there. So pharyngitis. The goal is to assess the signs and symptoms, epidemiology, and we're going to differentiate between self-limiting disease and those who need antibiotics. So here's a little review of the anatomy here. You've got your uvula and the tonsils here. This is really the kind of the key site here. We'll talk about diagnosing this. So pharyngitis generally occurs in infants and preschool children. It's mostly viral, okay? At 5 to 10 to 11 years of age, there's going to be a peak of beta strep group A infections. And there's also some information that suggests that some children are colonized with beta strep group A. So sometimes we get these false positives, but that's just something to keep in mind. If they are having an acute infection and you get a strep group A, then you want to assume it's an infection, not just a colonization. So adolescents, we also need to consider gonococcus, right? So if an adolescent is involved in oral sex, then there's a chance that they could get a gonorrheal pharyngitis, which will present exactly the same. So keep that in the back of your mind. If when in doubt, you can do a culture. You need to do a throat culture. If you just culture the strep after the rapid test, they're only going to plate it up on a blood agar plate. If you do a strep culture or a throat culture, you're going to get it on a blood agar plate and you're going to get it on a chocolate agar plate. And so that's really important that this is plated on both a chocolate agar as well as your other blood agar plate to see what grows up. So presentation, right? This is a nasty throat, right? They're going to have kind of a muffled voice. This is a tonsillitis for sure. They're going to have a sore throat. They may have a fever. They're not going to have cold symptoms if it's strep throat, right? They're not going to have runny nose. They're not going to have congestion in their ears. It's going to be like, I woke up with a sore throat. My lymph nodes are swollen here, and I've got this muffled voice, right? That's strep throat. They may have contacts with similar symptoms, and they're going to have anterior cervical lymphadenopathy. So let's differentiate between some of these. So viral pharyngitis can be caused by all of these things. We need to keep that in mind. So during summer, we may be more consistent with the adenovirus or the coronaviruses. They're going to cause a sore throat, maybe some conjunctivitis, and some cervical adenopathy. This is viral. It's self-limiting. Enteroviruses, also viral, self-limiting. We can get runny nose, cough, GI upset, or rash. The Coxsackie virus is going to be, it's also going to present with ulcerations in the mouth, on the mucosa, pharyngeal vesicles, and they look like ulcers. So it's vesicular in nature. It's also associated with hand, foot, and mouth disease. That's a Coxsackie virus. But the vesicles on the pharynx and the distal extremities is kind of the hallmark for this hand, foot, and mouth disease. Herpes simplex, so sometimes these kids will come in with a sore throat, but they've got all these herpetic lesions just in the mouth, but not on the extremities. They're going to spare the lips, but they're going to be on the buccal mucosa, so in there and on the lips, right? Herpes is on the lips. They're going to spare the posterior pharynx, but they may have cervical adenopathy. So those are kind of two differentiating characteristics between the HSV and Coxsackie. Coxsackie is going to be on the posterior pharynx, HSV will not. Coxsackie is going to have involvement of the hands and foot, whereas HSV will not. Epstein-Barr virus, so also known as mono, they're going to have fatigue, lymphadenopathy, they're going to have those kind of muffled voice, and in their differential, if you actually do labs on them, you're going to see a lymphocytosis, which is actually reactive lymphocytes that appear under the microscope to be closely resembling mononucleocytes. That's why this is incorrectly named mononucleosis, where it really should be called reactive lymphocytosis. Oh, that's a dorky lab joke. Okay, but usually resolves in about 3 weeks, but the fatigue does last quite longer. If this patient gets treated, where do we go here? If this patient gets treated with amoxicillin, they may develop a rash over their body. That is a side effect to treating Epstein-Barr virus with amoxicillin. It's a reaction, and that should tell you that, wow, that's actually Epstein-Barr virus. It's not some sort of a pharyngitis caused by a bacterial infection. So here's some pictures. Here we got hand, foot, and mouth, also the Coxsackie virus, known as the Coxsackie virus. Here, here's also the pharynx of that Coxsackie virus and some of the buccal mucosa. Here's the buccal mucosa and lip with the HSV infection, and this lip is just terribly beat up. And then here you've got a mononucleosis or a bacterial tonsillitis. Hand, foot, and mouth, HSV, Epstein-Barr virus. Okay, good. Beta group strep A. So beta group strep A causes 15 to 30% of childhood acute pharyngitis. At least one of the following that they're going to have. So this is that center criteria. So they should have, if they have strep throat, they're going to have cervical lymphadenopathy. They're going to have those tonsillar exudates like here. They're going to have a positive beta hemolytic streptococcus culture, and they'll probably have a fever. If they also have this sandpapery rash, it's a really rough rash that's equally dispersed over the torso, that is a hallmark for scarlet fever. So we need to make sure that we treat these people fully so that they don't have any sequelae of that, like valvular abnormalities. There's that rash. Okay. Group A strep, okay, because symptoms are overlapping, we tend to overtreat these people. Throat culture is really the gold standard. And this is not a beta strep group A culture, this is a throat culture. So the difference between a throat culture and a beta strep group A culture is a beta strep group A is only plated up on a blood agar plate, where it has a Haemophilus agar plate or the chocolate agar plate is utilized during a complete throat culture. So rapid antigen testing is also available for beta strep group A only. If it's positive, you can start antibiotics. If it's negative, then you can send a culture. Sometimes empiric treatment may be warranted. So if I have a patient that comes in with anterior cervical lymphadenopathy, no other symptoms, this terribly looking bad throat, and a muffled voice, I'm just going to prophylactically treat them. If they're kind of on the edge, maybe they have some nasal congestion and a very mild cough and a sore throat, and it looks more like a URI, then you may defer for the throat culture. If you just culture the strep, you're basically looking for beta strep group A only, but you have to realize that there is multiple strains of strep, and group A is not the only strain. They go from A to G. So how do we get this culture? Basically, we use the tongue depressor, and we are going to put it right in the back of that tonsil. We want to swab it, 2 swabs. One swab is for the rapid and the other is used for the culture. So treatment for pharyngitis, we need supportive treatment. So hydration, fever control, gargling, warm water, maybe some antiseptic sprays or lozenges. If it's Epstein-Barr virus, we want to make sure that they're not playing any contact sports for the next 4 weeks, as this could cause splenomegaly, which could result in spleen rupture if they were impacted over the left upper quadrant. We want to confirm the diagnosis with a monospot test. If it's strep, we can go for IM medication, which does not feel good but works very quickly, or we can go for oral penicillin BK, BID for 10 days, or amoxicillin. Antibiotics shorten the course slightly, but most of these are self-limiting. Transmission is not typically contagious after 24 hours of antibiotic. Retropharyngeal or peritonsillar abscesses are some of the sequelae to these infectious processes. Also rheumatic fever. If it will be reduced, the likelihood of rheumatic fever if the patient is treated properly within about 10 days of the onset of symptoms. So here's some plates that show us different types of strep throat. So there's a whole bunch of different strep species here. See A, B, C, D, F, and G. Not that all of them are particular pathogens, but some of them can be, particularly A and B and strep G. So here's what this looks like. So they plate this up, and when you're doing a strep culture, and you may get a different type of hemolysis. So that means that they're breaking down the blood cells to use for fuel or metabolism. And there are different types of hemolysis that can occur, and that helps these microbiologists to decide which type of strep. This would be with a strep culture. So that's just like a little bit of information for that. A retropharyngeal abscess. So a retropharyngeal abscess is a sequelae to a pharyngitis or some sort of a throat infection, but basically what it is this large abscess that you can see on the lateral film in an x-ray, and I'm going to outline it here. So basically you get this big area here that's full of infection. So they're going to be sick as stink. These people are drooling. They're going to be breathing poorly. That's going to be the stridor that they have. If it's a child, they're not going to be feeding well. Kind of a vague onset maybe, but these kids are sick as stink, so you need to get right on treating these kids. But the lateral neck film is going to show this enlarged area here, which normally with a normal film, you're going to see the neck tissue come down like this. And so there's all this extra something, right? And then we're going to get a CT with contrast that will be the most helpful for us. But When we see that, you know, we kind of compare this to a normal film, we see that there's a lot of extra stuff here that shouldn't be there, and that's that abscess. So this child needs to be hospitalized. They need to have their airway monitored, and they need to possibly be intubated if there's a need, or the airway's obstructed, or they need to surgically drain this. Paratonsillar abscess. So this is a paratonsillar abscess. You can see that the uvula is deviated away from the abscess site. Here's another one. So they're going to have a sore throat. It's going to hurt when they talk. It's going to hurt when they swallow. That can have this it's going to be adolescents and adults, and the uvula is going to be deviated. We want to refer to ENT. We've drained a lot of these in the emergency department, but not always. If the ENT is available, let them do it. But you can aspirate right into the bulk of it. You want to make sure that you stay as medial as possible so that you avoid the artery that runs back here. There's a tonsillar artery. And you don't want to go too deep. So what we did in the ER is you take an 18 gauge needle, you take the cap off the needle, and you cut the cap so that there's about 1/4 of an inch to 1/2 an inch cut off of that. And then you put the cap back on the needle so that you can only go so deep to aspirate in there. And then you're not likely to hit any structures. But you should definitely look this up on YouTube and have an attending provider walk you through it. I've seen people also use ultrasound, which is definitely more safe. But if there's no other way to do it, then we cowboy up and get it done. So at any rate, if you've got ENT coverage, don't go diving in there because they'll be ticked at you, and they probably like to do that. So here's a drainage of one of those. It's awesome video, so I encourage you guys to watch this on your own time. That's an active drainage of an acute paratonsillar abscess. So let's talk about lymph nodes really quick. All right, so lymph nodes, when we get an infection, they get inflamed and they get big. So here's the sites of the lymph nodes. Lymphadenopathy just basically means an abnormal size or consistency of lymph nodes caused by inflammation and usually the result of an infection. Generalized lymphadenopathy, presence of 2 or more non-contiguous sites of lymph nodes. We want to probably refer this patient for further assessment or an ultrasound. What's normal? So enlarged and palpable lymph nodes are noted in about 50% of healthy children. So they're just exposed to viruses, right? They're building their immune system. So these children are going to have just kind of a mild amount of lymphadenopathy at their baseline. If they're bilateral, that's usually a better finding. If they're unilateral, then we want to investigate that because that could be a little bit more concerning. Axillary and cervical regions are about up to 1 centimeter. Inguinal regions are a little bit bigger, up to 1.5, and that's normal. We want to get a good history. We want to feel for any supraclavicular, as these are always infectious. Malignancy does kind of present this way sometimes, so we want to see where these are at, and these are very abnormal. So if you've got cervical supraclavicular lymphadenopathy, then that is bad juju, and we need to investigate that acutely. The duration too, if they're in the presence of an infection, right? Yeah, well, your body's actually just responding the way that it should. But this is chronic, then we want to start to think about malignancy and possibly investigate with an ultrasound. So here's some of the things we take into consideration. You know, they have normal vitals. Are they growing normally? Are they having night sweats? Is there any tenderness? What's the consistency? Any overlying changes like an infectious process going on actually in the lymph node itself? is there drainage around the area, or are there any enlarged organs that are palpable on this patient? So here's some of the distributions and where they're at. Localized lymphadenopathy, so reactive lymph nodes, these are going to resolve spontaneously. There is acute bacterial lymphadenitis, which is actually infectious. So Staph aureus and Strep pyogenes need to be covered here. We also want to consider MRSA. We should treat this infection until it has resolved for more than 5 days. If there's a dental or periodontal disease, we need to cover for anaerobic bacteria. So that's going to be your clindamycin, because anaerobes live in the mouth and in the foot. So don't forget that when you're thinking about coverage options. If there's an abscess, then we need to think about surgical IND. If this is truly an abscess in the lymphatic tissue, we need to consult before we go cutting on this patient. So here's bacterial lymphadenitis and viral, probably. So my guess is this kid looks really inflamed. This is more likely bacterial. This is more likely viral, but that is just a guess. So we would want to do some labs. What lab would be elevated on this patient? Well, if it's salivary lymphadenopathy or mumps, we're going to see that the patient is going to have an elevated amylase, okay? So if the amylase is elevated, then we consider that this is a salinitis, right? So the salivary gland is inflamed, and we can treat that. Generalized lymphadenopathy, so infectious causes include mononucleosis, pharyngitis, kids that are exposed to multiple viruses. We can do serology, so we can check, for the viral capsid for Epstein-Barr virus. The monospot might be falsely negative if the child is below 4 years of age, because they're not able to mount the immune response that we want to see. And Kawasaki's disease can also cause this lymphadenopathy, but they're also going to have with that red eyes, cracked lips, and a rash. This is kind of the typical presentation for Kawasaki's disease. So they've got this kind of polymorphic rash. They're going to have mucus and some kind of vesicular lesions in their mouth. They're going to have really red eyes. They're going to have swelling of their hands and feet. And the risk here is that they're more prone to coronary artery aneurysms. So we always kind of keep that in consideration. Further evaluation, we can look at CBC on these patients to kind of differentiate between bacterial versus viral versus other infectious or like parasitic infections, something like that. So if we've got increased neutrophils fight bacteria. So that would be indicative of a bacterial infection. Increased lymphocytes, or miscalled monocytes, it would be reactive lymphocytes here. That's suggestive of Epstein-Barr virus. If they're bands, then that is basically a neutrophil that gets kicked out into the peripheral circulation before it should. And so that's a sign of a bad infection, because we're trying to get all the forces out there to treat this infection. And blast cells are usually malignant cells. They are cells that should not be making their way into circulation. These cells should be sequestered in the bone marrow. Leukopenia basically means low white blood cell count. That means you're losing the battle against the virus or bacteria. If there's no other causes, we want to be suspicious of some sort of immunodeficiency. If we have anemia and low platelets, we need to suspect a malignancy or some sort of bone marrow involvement. Inflammation or infection, we can do a SED rate. So a SED rate is going to be elevated in chronic inflammation, and a CRP is going to be elevated with acute inflammation. So that's the difference between those two tests. Sometimes they both they're not always exactly 100% clear, but in general, the lay person, the average provider, needs to know that a SED rate is elevated in chronic inflammation, whereas a CRP can quickly elevate in an acute process. So rapid cell turnover is seen with increased lactate dehydrogenase. This is also seen in malignancy, and increased uric acid. So those are some things that we can check. If they're uncommon or we're looking for specific infections, we can do serology for these to check. And for tuberculosis, we can do a PPD. So here's a further evaluation. So let's go a little bit farther here. So one thing that we can do if we're worried about malignancy or lymphadenopathy, we can take a chest x-ray of these kids. If we see this widened mediastinum, so check out how wide this mediastinum is here. This is also some kind of parabronchial thickening and widening. This is indicative of some sort of malignancy, so we probably need to do a referral for this kid as well. If we see calcifications, we can think about tuberculosis and histoplasmosis. So those are just some things to keep in mind. When do we refer? Well, if we've got suspicious findings, we want to refer. If we've got supraclavicular lymph nodes, we've got matted or really firm lymph nodes, this is all suggestive of potentially a malignancy. If there's no infection and we've got enlarged lymph nodes, that's concerning. If the child has fevers, night sweats, weight loss, any systemic features such as these red flag kind of symptoms, we need to refer. An abnormal CBC or chest x-ray, we want to refer to an appropriate center. We don't just want to treat these kids prophylactically with steroids to try to reverse the immune response. We want to find out why they are abnormally responding in the first place. So things that you can do is an ultrasound. I think that's where I usually start with kids. You can also do a CT, needle aspiration, or excisional biopsy, which are definitely more invasive tests. So referral outcomes, so 50% of reactive, of these enlarged lymph nodes are just reactive hyperplasia. So we can give people some peace of mind and just say, hey, look, 1 out of 2 of these, nothing goes on with it. But 30% can be a granulomatous process, such as a cat scratch, some sort of infectious process that's just kind of lingering beneath the surface. Mycobacterium infection or a fungal infection, and then 13% are a malignancy or a lymphoma. Foreign bodies, so this is moving on from the lymphadenopathy, we're moving into foreign bodies. So these are some of the sites where these foreign bodies get stuck. So kids love to stick stuff in their ears and nose for whatever reason, and you've got different sites that these can get stuck. So a lot of times we can go in and retrieve these. There's a lot of different ways to do that. There's no right or wrong answer, but we can also consult with ENT if we have access to an ENT doc. And questions. So questions, if you have specific questions regarding this, I would like them please to be sent to my email, and I will respond to them in a quick fashion. I will also provide you guys with a review regarding HEENT pediatric material that will be on the Heritage University website. And we'll go from there. I appreciate your time. Thank you so much, and we'll talk to you soon.